Hello all. As I see here Will, I see Katya, I see Haitham, I see Shaban. As we agreed together before, that the value of this courses or video is not in the participants only, but it is recorded and it is in documents. It is a document for what we are saying. It is a strong message in the world, believe me, and it is could be a game changers. So all these videos will be available in the web for all. Second thing, we'll have a panels for the first group of session, including this session and the next session, for to be ASCO international webinars. We send all these videos for experts, the highest experts in the world, and we'll ask them for their input, yes or no, critics, comments, whatever they like, in 10 minutes. Everyone 10 minutes. Then we'll discuss. We will not record the discussion between us, and then conclusion and future direction. What to do? So what to do? The world cannot continue as we are, frankly. So if you have critics, if you have another evidence, please tell us, tell the world. This is the future direction for the world. As you today, you will watch and record the seventh part of this series of examples of how to lower cost of the cost of systemic therapy. Next session will be about repurposing drugs and repositioning, and not only drugs but devices. Then we'll start series of radiotherapy, and we say clearly with the available existed facilities in the world, you can treat double or triple. How this message not listened? It should be listened. This is the trend of the future. And what is the future of radiotherapy in general? There are many changes. There are many future. And if you listen today, please forward the message that we give. This is not my message. This is your message. It's based on evidence all. How you listen, we listen today that there is $3 billion are thrown, are wasted in of leftover in vials of only some drug in the United States, and we speak about lack of resources. And there are many ways to treat doubles and triple the number of patients with the resource and that we have. Also, there are many ways to for researches, and you listen to this for in the next lecture in next week. A list of unlimited number of projects and research. So it could be a big movement focused on increased affordability of better value cancer care based on science and based on win-win scenarios. We are honored today that we have with us Kathy Graf, who is the vice president of global bioventure for global health, and she will be with us during this lecture, and then after she will have her presentation in 5:50, and then if the floor is open for you and her, we asked her to be later, because this advantage, because the number of persons who are joined are increasing, and we would like to hear that more people listen to Kathy really. My video is recorded, and it will be find all the session and the playlist for all videos available for all. Forward, use it an educational material in your institute, in your hospital, in your company. This is yours. Use it as educational material and add to it and criticize it as you as you like. Now I'll start the lecture, and I say, by the way, hi to Haitham, hi to Shaban, hi to the boss. Will is here with us, who runs the show. Hi, Will.
Hello all. I'm glad to be among you today. Today is the 13 lectures, a video lecture of our session of our global oncology implementing science GOIS course program. Is part of a global oncology university and our win-win initiative and movement. Today, we will present part 7 of 7 of examples of scientific exploration of resource-saving, better value cancer drug systemic therapy. That's to say, we presented before 6 parts, and all are recorded, and you'll find all in our website. If you would like to listen to a session or to PDF of slides, just send to us. And all is kept in the web. We send a link, and all our videos are recorded. So it will be like a forum. You can send feedback, you can send suggestion, you can send everything. This forum continuous movement to increase affordability of better value cancer care via scientific approaches. If these 7 parts were concentrated more than on cancer drug therapy, but there are other examples of also cancer drug therapy and devices on repurposing. This will be after in the next sessions. There will be also many examples about scientific exploration for research saving in radiotherapy, radiation oncology, radiobiomaterial, solar power radiotherapy. Publication movement, there is a special part about publications and the contribution of distinguished editors-in-chief of in the world, in the United States, in UK, and other parts of the world. I am, as you know, Ahmed Zawawi, Chair Win-Win Initiative, Chair of Board of Directors of Global Oncology University. And here is the web. Founder, President of ICDOC, ICDOC International Campaign for Establishment and Development of Oncology Centers. Was registered in Texas, USA. Past President of AORTIC, African Organization for Research and Training in Cancer. Professor of Clinical Oncology, Wisconsin University, Ismailia, and Chairman of Al Salman Radiation and Clinical Oncology Center, Port Said, Egypt. It is based these 7 parts about on chapter 15 of our book, Approaching Global Oncology, the Win-Win Model. Course Director, Professor Eduardo Gazab, David Kerr, Kiro Sikora, Wilfred Negwa, Cristina Stefan, Twalib Negoma, Ricardo Odesio, Luca Incroci, and I. These slides prepared by Dr. Fifi Mustafa Sayed, clinical oncologist at Wisconsin University, and reviewed by me. Disclosure of interest, as we is none, and but it is inspired from many the work with many organizations, society in the world, from many distinguished scientists in the world, and also long discussion and dialogue with sometimes tete-a-tete, but all are based on scientific publication by many authors. We don't give just opinions without base. Even when present as suggestion, but not as a point, scientific point. Everything is really for discussion, no problem. You notice that in most of our slides, that text is not short with few words or lines. Also, much as possible, we add some references, though all are based on scientific references. Along the GOIS program and its short lecture, we don't only transfer some information in a passive way, but also we raise brainstorming points and not offending points. The objective is that all will win more. All your feedback, interaction are welcomed. As we agreed together in the Win-Win Initiative and Global Oncology University, we adopted the flexibilities of thoughts, free flows of ideas, classical and innovative approaches, and that all be focused on scientific and practical implementation. All will get sustainable gain, including patients, community, healthcare, cancer care professional, industries. We are for flourishing, to that the industry flourish more and to avoid collapse and to avoid crisis. We are for that all will win, economies and all stakeholders. But before and after all, the most important is our patients, millions of patients everywhere in the world. Here, we started this lecture with control of the utilization of drugs as primary strategies applied in the example from the USA. In this case, in rich countries, the control of utilization should be mandatory in less in affluent countries. So it should be more mandatory in less affluent countries. If it is mandatory in the United States, so it is. What about less affluent countries? In the USA, policymakers have targeted Medicare drug spending from many angles to drive down healthcare costs. Current drugs prices propel the healthcare industry, rising the medical cost trend, which was projected to rise by 6% in 2020. And now is more. Medicare is not immune, accounting for 30% of the nation's retail prescription drug spending in 2017. The costs are projected to rise by 4.6% per enrollee over the next decades till 2030. Control of utilization of drug continue. In the USA, the primary strategy Medicare uses to limit the utilization of drug or another healthcare good or service is to limit coverage of the payment for it. The program does so by actively determining in which setting the drug is not reasonable and necessary. It's important through either national or local coverage decisions. When this coverage decision results in restricted guidelines for the use of the drug, the result is decreased utilization. For instance, in 2007, Medicare narrows the coverage of erythropoiesis-stimulating agents for cancer treatment. Medicare not only limited the type of patient who could receive this agent, but also the clinical scenarios in which they could be used as reported by Centers for Medicare and Medicaid Services. One of the biggest companies that sell this agent in the USA reported to their investor in August 2007 that changes in coverage for erythropoiesis-stimulating agent by the Center for Medicare and Medicaid Service would reduce the annual rates of the company from selling these drugs for approximately $1 billion to 200 million among Medicare patients. So from 1 billion to 200 million among Medicare patients. And this is the reference here. You find it. Control continues also the same point. In the win-win initiative, our goal is not at all against the sale of drugs per se, but we are for support saving the whole system, saving the whole system and benefiting all dimensions of cancer care in the world. The strategy of controlling the utilization of drugs by whatever mechanism in each country would assure a more reasonable and justified utilization of drugs or services. Not only we said the here example of drug, but it's for service in general. Otherwise, the chaos in their utilization in some less affluent countries open the door wide for the use of these drugs when they are not necessary. While, and here is a catastrophe, while omitting patients who are in great need. This is also due to the well-known widespread local corruption in many countries. This is a fact, unfortunately, which goes by many names as and it is covered by many names, not say corruption, but it's covered by many names like commissions, percentage, or rewards of any kind. This abuse of resources this abuse the resources of countries and individuals, patients and families without a cost-effective or measured outcome for patients. This finally could lead to increasing difficulties in the markets of those of countries at the forefront of newer products and innovation in cancer diagnosis treatment. The results will be cause more difficulties for all and for companies. Hence, the win-win initiative, we clearly support transparent, scientific, value-based measures. However, the implementation and global success need all key players to coordinate in a global campaign and with the notion that all will win, including an industry also, and economy. The win-win notion, the pharmaceutical response to interventional pharmacoeconomic study and other initiatives, choosing wisely, and other scientific initiatives to reduce the cost of cancer drug treatment. The major, this is very important, really, these types of interventional, and it is important to do these studies and to do optimization of the reduction of waste. Those that potentially lead to decreased cost and increased cost effectiveness of new cancer drugs. In fact, we pose question we pose the question: do all of you, all of us, all reader and stakeholder imagine that the leftover cancer drugs in vials that goes to waste cost around $3 billion annually in the USA? $3 billion annually in the USA. This is the leftover. It goes to the waste. This is because many top-selling cancer drugs in the United States are only available in single-dose vials. We hope that this improves by time. It's really, there are many things now. And the vial only comes in one size. This is particularly true for drugs whose dosage is based on patient weight or body size, and that it comes in single-dose packages. The sum of $3 billion. You imagine what it represents. It represents the sales of leading radiotherapy equipment manufacturer, Variant Medical Siemens, now Variant Siemens Healthineers, for the whole world in the year 2019. And now it's slightly higher, and this can include all, not only registered machine, informatics, all their products, spare parts, everything. The sales is equivalent to the leftover waste in vial in USA only annually. And after, do we speak about lack of resources? Do we speak about global fund? Speak about, no. First, we should speak about how we react reasonably and in sound economic way in which all will win. Even industry will find resources to invent and to do many things forward. This includes all the product. As I said, this also constitute more than 50% of the market of radiotherapy equipment in the world. Not only variant, but it constitute about 50% of the market of radiotherapy equipment in the world per year. All the market, the leftover in drugs. Do you imagine? Surprisingly, the waste of $3 billion US dollar could be cut down by providing this drug in multiple sizes of vial. Do you see how there are solutions? Another suggestion that need further study is to follow a system of sharing vials by pooling patients who get the IV drug within 6 hours on the same day. The open vial has to be kept under an IV hood for no longer than 6 hours, and then it must be discarded because sterility can no longer be guaranteed. This is as agreed by Medicare and Medicare services, but it's still not accepted by Centers for Disease Control and Prevention, CDC, United States. The increase in the amount of drug sold per treatment lead to increased profits for manufacturers. It is sad to see what it has been published by many other authors. You return to this, there are many references here, lead to increase, which is that there is an increase in the unjustified profits of oncologists. It's not companies only, but oncologists and hospitals in the United States and some part of the world. And less affluent country, surely, the low middle income country. And we speak about lack of resources, no money, and charity. We need charity. Even if the profit represents small percentage, they can equate to large amount of money, given that many of these drugs cost thousands of dollars per vial. Several policy options should also be explored. Regulators could require manufacturers to provide drugs in a reasonable set of size options to ensure the amount of versus drug is low, say 33%, for example, or a similar quantity. An alternative to that would allow a manufacturer to the freedom to select vial size, but also require them to refund the cost of the leftover drugs. This option could be achieved through certified disposal and a virtual return. If we are seriously would like to see more access to cancer drugs in the world, even in affluent countries now, there are many difficulties and in skyrocketing rise. We should go to search for solutions and serious solutions based on science and without compromising the outcome on patient in any way, and to keep the economy, to keep even the sales, more treatment of patient, more number of patients treated, so it will increase the sales at the end. All will win. Several policy options should be explored. Policymakers should revisit the current FDA guidance on appropriate packing for intravenous drugs in single-dose vial and encourage FDA, the CDC, CMS, and the United States Pharmacopeal Convention to reconcile their views on vial contents and vial sharing. We stress on the United States because it is the biggest market, it is the biggest the innovation are there, many of the innovation, and it is an example how we can expect improvement of things in less affluent country when the big example should be the example in everything. There is no other way because they set the drugs. It could be also suggested in all countries that the patient funder or the insurance company should pay for the prescribed dose only. If there is large amount of waste, the manufacturer refunds the hospital or the physicians. Thing should be taken seriously, by the way. And it could be taken seriously if you all adopt it, if you all give more suggestions, if you all going together hand in hand. We didn't invent anything. I didn't invent anything. All is published, all with references. I don't claim any invention. It could be also be suggested in all country. If there is a large amount of waste, the manufacturer refunds the hospital or the physicians. This option could be achieved through certified disposal and a virtual return. This step could in turn lead to healthcare cost saving by all oral patent protected oncology products suggested that an approximately for at least 50% saving. 50% saving at least may exist for large number of drugs without foregoing outcome on patients. And there is reference again, Professor Rattan and Lichter, Goldstein, Dr. Bash. There are many very wonderful works, really, so very scientific. Some examples are cited here from the literature. One example is that the Velcade, Portozomib, which is used to treat multiple myeloma, is only available in the USA in 3.5 milligram vial, which is much larger than the average required dose, which Dr. Bash and colleagues calculated to be 2.5 milligram. That figure is based on the drug's dose of 1.3 milligram meter square and the average cancer patients. There are references here, Bash, Rattan, Singh, also, and Chang, and have the very nice literature. And in their literature, you'll find other literature. So also we'll provide all information that you can go yourself and search for this, and you search for, make Google search, and you'll find many, many others. We didn't invent anything. And the question, why all these things not taken widely? And this will be the only way is that adopted by you. You are the leader. The win-win movement and win-win notion is not an invention. It is a movement by you, for you, based on the scientific work of many distinguished scientists in the world. Another example is the Pempro Keytruda, which was previously sold in 50 milligram vials as a powder that need to be reconstituted into liquid. However, in February, surprisingly, in February 2015, the manufacturer introduced a larger 100 milligram vial as liquid, and 50 milligram become unavailable. Merck withdrew the 50 milligram vial and replaced it with 100 milligram vial. What is this? I'm just asking. I am innocently. Why? The increase in revenue from this switch is substantial and estimated to add about 1 billion in revenue over the next 5 years. Dr. Bash and colleagues arrived at this estimate using the example of 70 kilogram patient who required a dose of 140 milligrams. The drug dose is 2 milligram kilogram per kilogram. Look, this is the estimation of Dr. Bash, and there are published. And if you have anything, we are very open to receive any critics, anything. If you are saying is not right, say to us. We correct. We are not. We don't claim that we owe the whole truth or the whole science. Nobody is perfect. But if you have more suggestions to add to this and to improve this, please do and write and publish and write to us. This is your movement. This is your web. 50 milligram vial would previously have been required, leaving only 10 milligram unused. But now the supply is limited to 100 milligram and 60 milligram is wasted. Why? We know. I'm asking innocently. Dr. Bash pointed out that Pimpro was approved in Europe and it is being sold in the smaller 50 milligram vials. So it is possible. Portozumib is sold in 1 milligram vials in the United Kingdom. One would have to assume that this is due to closer scrutiny of pricing in Europe, precise follow-up. In contrast, it is quite possible to market a drug with negligible waste. One case is point to bendamustine, which is sold in a variety of vial size: 25 milligram, 45 milligram, 100 milligram, and 180 milligram. That can be combined to reach the dose of 100 milligram meter square, almost precisely. Almost. The authors calculated that only 1% of bendamustine is wasted. So there are many other successful examples. We are not speaking about theoretical or dreams. We speak about scientific solutions and realistic. It could be done if we have the spirit to solve. A similar example can be seen in setting of oral drugs. The U&I program is a very nice program, really. Read about it, and there are reference here, and you read for Singh and Ratan and Cohen. Cohen is very excellent, really, publication in British Medical Journal. The U&I program for ibrutinib aimed to remove the 140 milligram capsule from the market, limiting dosing flexibility while pricing newly introduced tablet formulation 140 to 560 milligram at 3 times the price of 140 milligram capsules. In a story of limited but encouraging success, the drug maker eventually reversed ibrutinib's U&I program following public outrage. The English High Court backed the National Health Service off-label use of bevacizumab to reduce cost despite manufacturer objections. English High Court. This reference 81 here. It is a Cohen, and it's very when the name of the reference itself is nice. Is when right to offer patients Avastin. Other studies used to oppose scientific studies that aim to lower the cost of the new cancer drug is interventional pharmacoeconomic studies, IVPE. It's very interesting, really. And choosing wisely campaign is that, according to multiple experts and authors, pharmaceutical companies adopt tactics that include paying physicians to prescribe on label in position to experts who study the dose, the escalation. Please refer to our first to the outline and our first part 1 of this series of 7 lectures. We cited the limitation wrote about choosing wisely campaign, and also about clinical oncology sense and all this very nice initiative, but there are limitations, and we cited that. Please give your opinion, and but every effort to make solution should be respected, surely, and we get use of it. We don't mean that we have the full truth or the full wisdom on the full perfect thing, but our view till now is that there are limitations according to what is published of choosing wisely and to oncology, sense in oncology and some other, but it is a very positive step forward. They are very positive step forward. Moreover, there are still legal and regulatory actions that discourage IVPE despite of that. You imagine this. During the course, there is a break. We give a slight break here, and we'll continue. If you have any question, or to save your time, I'll continue soon after a few seconds. And if you have to give just a chance for if you have any leave question to send or to chat, and also we reach program of very distinguished speaker.
Okay. Hello. I'll continue the next part of the lecture, so we'll give more ample place for more than half an hour for cartograph and her important video and discussion, and for all of you to discuss the points. So we'll continue now.
We continue. We have explained since the start of the win-win movement and the different parts of this book that we are not calling for confrontation, for fights between different stakeholders. It has become clear that the majority of cancer patients have no access to cancer care, or at least no access to value-based care that is adapted to patients in their specific community. Shall we continue like this in many parts of the world? I think that nobody likes this. This serious burden that affects millions of cancer patients and their families has increased in recent decades and will be further aggravated in upcoming years. Forget about agendas about improving 2030, because we have before many agendas for 2020, for 2025, but no indication that this problem will not be aggravated in the upcoming years. So we have to work together, all initiative, all agendas, all campaign, all to be a big international scientific campaign, all will win. The impact of COVID-19 and post-pandemic situation add another negative crisis, but we learn from it. The whole system will suffer more the risk of collapse or the failure of some sectors. As we already mentioned in our books and many parts, and as an ASCO report sadly stated that nearly 40% of cancer patients may say abandon science-based for professional oncology care because of the fear of skyrocketing cost and the burden to them and families. Return to ASCO report, you will find this, and you will find a reference here. We have a video here with Professor Eduardo Gazab. We cited all this, and is also referenced in our book. ASCO reports. It is sad. So what is about less affluent countries? Hence, we can imagine how the state of affairs is tragic in less affluent countries and how it will be aggravated in for the coming years. To be realistic in the real world, there is no doubt about the essential role of industry in creating progress and innovation for cancer diagnosis and treatment. We are for and not against, surely, because this is logic. The win-win notion implies that all will gain, which includes the manufacture of cancer drugs and radiotherapy devices. This notion could be expanded to other non-cancerous diseases. So the win-win. Yes, we concentrate in cancer care and control, but the concept itself could be expanded to other non-cancerous diseases. and other health care. The win-win movement, we consider all the incentive of all stakeholders, including industries and colleges, hospitals, and government, in order to achieve the objective of access to care for millions of cancer patients in the world. When you say commission, when you say percentage, we are for increase that healthcare professional, cancer care professional gain more and live much better. It is possible. You'll see together how to make this. I know that there are many genius and intelligent people in the world who can do much better than are presented, but it is with the concept of the win-win. But it is stimulus. Consider it as stimulus, not a complete solution. Stimulus for a direction. For further details, we ask the reader to view an example of the win-win publication using the online access. Here you find many articles. These download free. And this article was the shortage of essential cancer drugs and generics in the United States of America. This was the title of this reference. Global brainstorming direction for the world. Please write to me your comments, or write to us. We refer all your chat to, not to me, but to all the directors, all the experts. We have more than 100 distinguished contributors in our work. This also explains why we tackle the situation to access cancer care, the shortage of cancer drugs, and pharmacoeconomic intervention in the United States, while our scope is the whole globe. And this is, if you read this article, we started from shortage of essential cancer drug and generic in the United States, but the second phrase, global brainstorming direction for the world. It's clear that most of the key players in innovation in the field of cancer treatment and cancer drug, old and new, are in the United States, Europe, and Japan. Moreover, the decision and regulation of the FDA and guidelines of the American Organization for On-Label Prescription are at least viewed, if not followed, in most of the world, despite differences in communities, ethnicities, in pathologies, and socioeconomic status. We come here, this was a very important point. We are dealing with the real world, to be realistic. Repairing the compensation system used for the oncology in the USA as a first and huge example, but it should be repaired. It's repaired in different parts of the world. It should be repaired in different parts of the world, not repaired here. This mistake. It should be repaired in different parts in the world. As we deal with the real world, the notion of the win-win movement consider the incentive and the interest of all stakeholders. It is vital to explore the issue from the oncologist perspective as well. Medical oncology is a cognitive specialty without many associated procedures that provide financial boost. So many private oncology in the USA depend on the incentive of the drug prescription reimbursement. And also, by the way, in many parts of the world. Here in the title, I repair it in the PDF. But it should be repaired in different parts of the world, not repaired. Hopefully, it could be repaired in different parts of the world. The system must be repaired, so the oncologist may be correctly remunerated for their service while avoiding ethical conflicts. To be transparent, patients should have access to information regarding all the kinds of profit that might influence an oncologist drug choices and thus affect costs and co-payments. The first proposal is to pay physician salaries as most as academic centers to do so in United States. But not all, so that oncologists do not have to rely on chemotherapy sales for income. The second proposal is to adopt clinical pathways in which the fees of practice are paid for disease management and not based on the price of prescribed chemotherapy. This could be the sound medicine. The New York Times published a plan to overhaul cancer care in the United States, which suggested that payment system needs to change from fee for service toward a system of bundle payment. And here is the reference, and many references for Shabnar and Getzman, really, and Smith. These are wonderful examples here and references. This is not far from the European idea of remuneration, as I said in France, remuneration for the act for oncologists, which involves the payment of one fee for all service of caring for cancer patients. It's proposed in Europe and proposed in some countries like France. Proposed that to be something called payer à l'acte. Payer à l'acte. This is for the act, not for what you prescribe. For example, you see a case of Hodgkin lymphoma, you make the plan of treatment. That fees for plan of treatment, no, even if the plan is to refer to some investigation or something, but or to start the treatment or not. This is pay à l'acte, pay remuneration for the act of oncology. It's called prescription of the for follow-up for something. This is à l'acte, regardless what you prescribe. Hence, the oncologist would be paid for consultation, advice, partial diagnosis, or the treatment, or he provide regardless, or he or she provide regardless of whether he or she prescribe or not what he or she prescribe. This would remove the incentive to prescribe more expensive drug when older generics are equally effective. The oncology community cannot make this change alone. We can't. I am oncologist. I am a physician. I am a clinical oncologist. I do medical and radiation oncology both. But we can't do as so. I speak frankly. We can't do it alone. We can call of it. I do this person. But anyway, I speak in general. The government is deeply involved and has to help. Everyone engaged in cancer care needs to help improve it. The third proposal involves remuneration for pharmacists that depend on the number of prescriptions served regardless of the content and the number of drugs presented in the prescriptions. Pharmacist is a main partner in this process of our work. Main partner. It may be an audacious or daring idea. However, innovative solutions particularly need to be generated when we are faced with a complicated problem with economic complexities. As mentioned earlier in this chapter and in many in our books, in our presentation, in our course program, we have many examples. There are many scientific examples of reduction of cost without sacrificing efficacy. As shown in published example, for a new oral oncology drug alone in USA, we could save $94,000 of the $100,000 per patient year in saving. You imagine, in some examples like this, with similar opportunity in long-lived parental monoclonal antibodies, then we should advocate for more studies in the world in this direction, which should be the leading trend in the real world. We call, frankly, that what we are saying, and it's not ours, but based on many publications, be the leading trend in the real world. How? By you. Anyone alone or 2 or 3 person or even 100 person is not enough. But by you improve this modification of these the leading trend in the real world. In the win-win movement, we see that with more scientific studies, we need more and more and more and more scientific studies, research, and initiatives like some of the important examples cited in this chapter or in this series. It is just stimulating. The more the affordability of value-based treatment could be improved. Education, training, studies, research, and publication directed to those objectives are essential elements. And now we arrive to somewhat Global oncology implementing science, global oncology, focus on education and training, focus on what is focus on approaches to increase affordability of better value cancer care via science and giving example. That is explain what is we are doing together, but it's just stimulus based on you. Is remarkable increase of affordability of better value cancer care is possible? Yes, 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 yes. But it needs all of you. The oncology community cannot make these changes alone. Governments are deeply involved and have to help. Everyone engaged in cancer care needs to help to improve it. Hence, there is a great need for global win-win campaign in which all find an international platform for all. While the internal entity, independence, freedom, and credit for each contributors. The policy or entity of any society organization will not be touched, but it's freedom completely. But or the body organization or individual, but platform for to coordinate and with one objective, in all will win, and all the independence and internal entity of any body or organization or individual are strictly respected, and the credit will be for the doers. We don't claim, no, even the forum will not claim anything. I see here Emmanuel. This is a nice reference from New York Times. Final note: as we see in the direction of and in some part of this program and books, article presentation, please visit our website. And this is your website. This is yours. Interfere, suggest. We present example of the published study of many authors and scientists directed to lower the cost without compromising the outcome on patient. We emphasize that we don't claim that we present the whole wisdom or the final solution for challenges or the question of affordability of cancer care worldwide, but the objective is to be as a caller or as advocate for all colleagues and key players to contribute in forming global campaign and movement in which all would gain and win. We don't claim any credit. All colleagues and stakeholders readers are invited for sending feedback, suggestion, and idea. Focus on how, and this is the program, all focus on how to increase affordability of better value cancer care to one of the available link. Send this to one of the available link. This reply will be via email or some via website, and all will be directed to many experts. You will see everything, and so continue and. If there is anything could be seated under your name and affiliation. We don't claim any praise or glories or take the work of others. Anything we cite who is the author and who is the sender, who is the owner of the suggestion, whatever it is. So it is continuous global forum and platform for which all are invited to contribute and treat some of the many approaches and initiatives. We personally don't claim any personal credit. The win-win movement and this book belong to all. This is the end of part 7 of 7. We count on all of you, and we'll continue after for repurposing and other approaches. And we have many exciting things which come in the upcoming sessions, and particularly with many other modalities of cancer and for repurposing, for drugs, for many things. This is yours, and based on your contribution in your work and being together, going forward hand in hand. Thank you all. Bye-bye.
Thank you all. Now I have the honor to present the lecture video of Kathy Graf. And after the this short video, she is among us, and she introduce their very beneficial initiatives and approaches in the world of bio-venture global health. This is the video of Cathy Graf. Welcome, Cathy.
Good afternoon, and thank you to the organizers of the program for inviting me to speak today. My name is Katie Graf, and I'm with BioVentures for Global Health, or BVGH. BVGH is a nonprofit organization that was established in 2003 to engage the biopharmaceutical, life science, and diagnostic industry in programs to improve global health. Africa is facing a cancer crisis that will see a doubling in the number of new cases and deaths by 2040. This crisis is driven by several complex and interrelated factors, such as inadequate access to cancer medicines, insufficient healthcare infrastructure and staff, African ethnicities' unique and intrinsic tumor biologies that are underrepresented in clinical trials, as well as limited public awareness of cancer, leading to late-stage diagnoses that have poor treatment outcomes. In 2017, BVGH launched the African Access Initiative, or AAI. The goal of AAI is to improve cancer patient outcomes in Africa by establishing sustainable access to high-quality cancer medicines and technologies, strengthen healthcare infrastructure, build clinical oncology capacity, address the cancer data gap in Africa through clinical trials, and expand awareness of cancer in Africa. We're currently working in 7 African countries, including Cameroon, Cote d'Ivoire, Kenya, Lesotho, Nigeria, Rwanda, and Senegal. Within these countries, we have partnered with the ministries of health, as well as hospitals that are treating cancer patients. We also partner with private industry, academic institutions, and cancer societies to implement all of our programs. Everything that we do is driven by the priorities of our partners in Africa. This includes the priorities of the governments within which we work, as well as the individual hospitals within which we work. To understand our hospitals' priorities and needs, we first conduct a comprehensive needs assessment to understand their capabilities, gaps, and areas to prioritize. This assessment includes information around the number of cancer patients that the hospital diagnoses and treats on an annual basis, how they diagnose their cancer patients, how they treat their cancer patients, and what products, including cancer drugs, they have access to or need access to. And for those products that they currently do not have access to, we ask why they do not have access to these products. Is it simply an affordability issue, or is there a lack of access due to supply chain issues? Using this information, we help the hospitals to accelerate their access to affordable but sustainable access to quality cancer medicines. So we work with the hospitals as well as the in-country ministries of health to prioritize both the cancer drugs as well as the cancers that their hospitals and patients need access to. We then work with multinational pharmaceutical companies to source affordable prices for their cancer products. We only engage companies that use and produce US FDA-approved cancer drugs, thereby ensuring that all cancer patients in Africa have access to high-quality cancer medicines. Once we have the pricing available from the pharmaceutical companies, we work with our hospital partners to forecast their drug quantities and needs, help to budget, as well as help to procure the drugs, including working with supply chain stakeholders, coordinating with the company on behalf of the hospital or the government, as well as tracking the products from port to patient. Once the products arrive at the hospital, we keep in touch with that hospital to understand how they are using the product, where they're running low, and where they might run into issues with expiration dates. To date, more than 4,000 cancer patients have been treated leveraging products that were made available through AAI. These include chemotherapies, targeted and hormonal therapies, supportive treatments, and more. All of the products that were delivered were prioritized by the hospitals that purchased those products. Similarly, the cancers that were treated by those products were prioritized by the hospitals. And more than 17,000 packs of those products have been delivered to Cameroon, Cote d'Ivoire, the DRC, and Nigeria. In addition to helping the hospitals to source the products, we also work with the hospitals to develop custom drug budgets that are based off of the drug prices the companies are supplying, the specific cancer type or types that the hospital is interested in treating, as well as the NCCN guidelines or the treatment regimens that a hospital uses. Based off of this information, as well as the number of patients that the hospital treats, we can help to create a budget that covers the entire treatment regimen per patient or for a single year of treatment. We use this information to help the hospitals select which products to procure, as well as the amount of products to procure based off of their patient numbers. We can also use this information to help the hospital to forecast costs based off of available funds. So we can look at the different regimens and the different expected costs for those regimens, gauge how many patients they have and how many patients they could treat per regimen and per cancer type based off of the available funds that they can have in a year. Recognizing that not all patients are able to afford even the access prices, we also work with hospitals to develop customized pricing models using a patient poverty index. These indices are developed in partnership with the hospital and are customized to the specific demographics that are a priority and prevalent within a hospital's patient catchment area. Using this information, we can develop a tiered pricing model that provides numerous tiers, including free or compassionate care to people that are living well below the poverty line as according to that poverty index, significantly subsidized prices for patients living at the poverty line. Drugs could be sold to patients living within a middle income at a nominal markup, and those living well above the poverty line may have an extra cost added to theirs to offset the subsidies of the first two tiers. Beyond helping our hospitals gain access to cancer medicines, we also work with them to identify where they have gaps in their diagnostic and treatment capabilities so that they can use those products that they gain access to in a safe and effective manner. Understanding the gaps, we then work with a variety of international experts located around the world to design customized training programs for those hospitals. We work across the continuum of care to support any gap in our hospital's needs, and this includes early detection and screening, diagnosis, treatment, as well as patient management. We've leveraged both in-person training opportunities, multi-week digital lecture series, as well as long-term digital mentorship to help hospitals fill their gaps and provide their patients with the top care they need. We also work with the hospitals to identify where they have gaps in equipment as well as other materials in order to implement those trainings. And we've to date delivered donated microscopes, textbooks, as well as helped the hospitals to install or repair laboratory equipment. And lastly, recognizing that patients have the best chance of successful outcomes using those cancer drugs if they're diagnosed early. We work with local partners to help raise local awareness of cancer in Africa. We have worked with hospitals in Nigeria to launch radio jingles to encourage individuals to learn more about cancer, talk to their physicians about cancer, as well as to seek cancer screenings as needed, as well as developed posters, handouts, and other materials to both educate patients about cancer, as well as cancer patients about their disease. All in all, the goal of this program is to improve cancer patient outcomes and to prevent cancer from being a death sentence across the African continent. I thank you very much for the opportunity to speak today. And if anyone has any questions, I have noted my email address in the slide at the bottom, and I encourage everyone to visit our website to learn more. Thanks.
Thank you very much, Kathy. And I would like to say that BioVenture for Global Health is one of the great partners with what we are doing and support also, and you'll find their logos and information about them in our webs also. And thank you all for and thank you for global for BioVenture for Global Health. And now the floor is yours, Kathy, from now till 5:25. If you give more information about an update about BioVenture for Global Health, and also we have leaders from as you see the participant, if anyone would like to participate, to add something about BioVenture, about the issue in general, Professor Twalib Ngoma, Dr. Beatrice, all our colleagues, all our dear colleagues, and at 5:25, I ask my brother Will to make the closing note for 5 minutes. The floor is yours now, Kathy.
Thank you very much, Prof. It's a pleasure to be here today. And I think I don't necessarily have any updates from that presentation that I gave, but I would be very pleased to take any questions that anyone might have. And while we wait for questions, I see we have Dr. Ava, Prof. Will on the line, and one of the aspects of AAI that I mentioned is our clinical trial work, which Dr. Ava and Prof. Will are part of. And I would also open up the floor if they wanted to talk about their experience on the Hypo-Africa clinical trial. Of course, Prof. Ahmed was instrumental to getting the Hypo-Africa program off the ground as well. So again, happy to take any questions, and if Dr. Ava and Prof. Will, if you'd like to make any comments about that as well, the floor is definitely yours.
Which question? Okay.
And if it's easier, you can put the question in the chat. I do have it pulled up so I can read out the question.
There is no question. So I think Abba, if you would like to say something, and we hear maybe from Twalib Ngoma also, because he was in the hypofractionation, and from Dr. Beatrice, and all of you, please, if you would like to interfere now or send emails, send, and you have also the emails of Kathy.
And I'll put my email address into the chat box as well for everyone eats best.
Also, I see Nahla Gafar from Sudan, and she is, by the way, now the vice president of our aortic in North Africa.
Yes, hi everybody. Thanks, Dr. Ahmed Zawawi, for this invitation, this kind invitation. And also, sorry I joined you late, so I didn't attend a lot of the session today, but I'll be a very adherent attendee.
Thank you, and you will have all the videos. I send you the link to in the emails, and you have all the video. You are free to distribute to all your colleagues.
Okay.
If everyone advocate for 10 colleagues, and every one of the 10 will advocate for another 10, then it will be the trend in the world, and that we hope to do, to see is to change for the better.
Yes, thank you. I also read about the book that you sent me, and I passed it to my boss at the WHO office. So I will be hearing her comments next week.
Thank you, thank you.
Mm.
This is yours. The initiative is ours, all of us. It's not mine. It's not initiative. It is ours. It is our depend on us.
Okay.
Katie, if you would like to add something.
Nothing to necessarily add. Thank you again so much. And I think what you emphasized in your presentation and the overarching narrative of the course, that everything needs to be win-win, that's really what's going to be sustainable. I think it's, really applaud the work that you and Will and others are doing in this area. Let's see, I do see a question here. So the question is from Ghana, and the question is, do you deal primarily with the hospitals or more with the government as the link, then access the hospitals through the ministry, for example, when needed? What I would say is that it's on a case-by-case basis. In some regions, we work directly with the hospitals. The hospitals have more leverage to make their own procurement decisions and who they procure from, what they procure. For example, in Nigeria, we work directly with the hospital leadership as well as the pharmacy teams to understand their drug access needs, and then work with them to establish affordable access agreements directly between a hospital and the manufacturer of the product. In other instances, we work more closely with the federal government of the country, as they may have more restrictive or streamlined procurement processes. And so it really depends. We don't want to create a new system. We want to use the supply chain and the systems that are already in place, because again, we want this to be sustainable. And so we're just there to help connect the different pieces together, advocate on behalf of the country as well as the hospital to ensure affordable access to high quality cancer medicine. Any other questions?
Dr. Beatrice, you would like to say something? If you are there? Or Twalib Ngoma? Then Will have a long history for cooperation with BioVenture Global Health. Also, he's the boss of this initiative. So I would like to hear from him and to discuss with Katie what he would like. Oh, Petra sent something interesting.
Can you hear me?
Yes, Will. Excuse me. Can we ask Beatrice to say something, because she sent something?
Okay, sure.
Beatrice? She said we need all hands on deck to change the narrative about cancer in low medical income country. The win-win initiative is one sure way to go. Thank you, Beatrice. So, Will, please. Will. My brother Will. Is there a problem connection or what? I don't know. Professor Wilfred Negwa. Will.
Perhaps while Dion is, I think what Dr. Beatrice noted is really important. And that's something that we take to heart because we recognize in order for drug access to be sustainable and driven by the priorities of our hospitals and country partners, it has to be win-win, which means BVGH has this unique perspective given that it was founded to engage the biotechnology and pharmaceutical industry. So we have that perspective of what a company needs in order to enter these markets, and so we can help to negotiate with them. We can speak their language, but all with the view in mind to drive affordable and sustainable access to high quality medicine. And so I think that really underscores this idea of win-win that is, yeah, as I said, essential for the sustainability in the term.
Thank you very much. Once again, if any of your colleagues would like to ask Kathy something, send to our emails. And if you miss it, just send to us. And the link in the for BioVenture Global Health is in our web also. If you like, you can contact all information about them. Will send that sorry unable to speak now, but appreciate the work of BVGH, this is BioVenture for Global Health. Sure, we appreciate this, and we would like to continue cooperation. And thank you for your support. If there's any other question, we can close. If there is no other question, and you can close the session, Kathy, please.
Happy to do so. So I thank you again so much for the opportunity to join, and thank you all for attending. And I think that the course of the series is really important, and I can't thank you enough for organizing this multi-week course.
Sorry, Abba interfere now. Yes, you are there, Abba. Okay.
Yes. Al-Zawawi?
Yes, please interfere. This is Kathy. Speak to Kathy.
Okay, right. Good afternoon, everybody. Kathy, thank you so much for the wonderful work that is happening with the BioVenture of Global Health. Actually, the aim of the global win-win situation and the BioVenture have almost similar aims. We can see that your work is toward closing the gap from the low middle income country and other Caribbean country, which is in keeping with the win-win collaborative network. And I think there is more to learn the more we share. And holistic approach you mentioned, I have seen some group of people at the palliative care levels. And I think one thing that is, I don't know, one thing that is, I feel is a gap is preventive at the primary health care. Along the course of doing that, a lot of investment is happening for the treatment. I think screening has a lot of potential, preventing such as cervical cancer and reducing those crises, especially in low middle income country where resources are limited. But BioVenture is doing a very wonderful job, and we will all take the leverage and opportunity of that to collaborate more and see how we can be able to establish in our various centers. And Al-Zawawi, thank you for coordinating. It's really wonderful to have all of you. Thank you.
Thank you. The initiative is yours. This is your initiative. Katy, you close the session, please. And all video, I'm sorry, all video of this old session, it would be available. And please, if you have any queries, send to us. And the video, and there's no copyright, this is yours. Use as educational material and diffuse information. Thank you all. Katy?
Thank you. Yeah, I'm not sure what how to close it other than to thank you so much, and I wish everyone a wonderful rest of your day and evening.
Thank you all, and bye-bye. Bye-bye. Thank you all.
Thank you.
Bye-bye. Bye-bye.